to outline how to go about it. Now, next we go on to Dr. Sandhya, who will be talking about incisions and capsulorhexis. As we know, the importance of the incision, the astigmatism induction, and also the perfect capsulorhexis, which will keep the ELP, effective lens position, is very important. Dr. Sandhya doesn't need any introduction. She is a senior consultant, cataract and uvea in Giridhara Institute. Over to you, Dr. Sandhya.
Thank you, Dr. Soni. Perfecting incisions and capsulorhexis for optimal vision. We all know how to do a normal rhexis, so I'm not going into the detail. And an intact rhexis is essential for a good corticocleavage hydrodissection, safe removal of the cortex, and also for in-the-back placement of the intraocular lens. An intact capsulorhexis offers various surgical advantages. In case of an unexpected large posterior capsule dehiscence, the capsulorhexis can be used as a contingency platform on which the IOL can be placed, preventing it from dropping into the vitreous. Now, the overall diameter, most of the foldable IOLs are short for sulcus placement, hence sometimes they may not be very stable. So in case of a PCR, the haptics of a 3-piece lens can be placed over the rhexis, and the optic can be taken under the rhexis and captured, and this will give long-term centration for the intraocular lens. For this, the rhexis size should be around 4.5 to 5 millimeter so that the optic can be captured. Now, proper sizing of the rhexis is also important. So, most of the IOLs have an optic of 6 millimeter. So, we should aim for a rhexis of around 4.5 to 5 millimeter so that this uniformly overlaps the IOL optic all around, giving axial stability to the intraocular lens and avoid post-op refractive surprises. This is all the more important in case of presbyopia correcting IOLs. Most of the modern lenses have got a square edge, so the circumferential overlap of the optic by the rhexis will produce a shrink wrap effect, wherein the posterior capsule is kinked by the edge of the lens, and that prevents migration of lens epithelial cells from the equator to the center, preventing posterior capsule opacification. Now, a small rhexis is more prone to damage by instruments during phacoemulsification. Here I was trying to remove the small epinuclear plate, and that injured the rhexis. Also, small rhexis are more prone for capsular phimosis, and capsular phimosis is more prone in patients with pseudoexfoliation and zonual weakness. Here, this patient had generalized zonual weakness, and phaco was done with the help of capsule tension ring and capsular hooks. And at the end, multiple nicks were made on the anterior rhexis margin after the implantation of intraocular lens, so that the centripetal forces acting at the capsulorhexis margin is less, and that will reduce capsular phimosis in future. In this patient, when the intraocular lens was implanted, the haptic was crowded and there was eccentricity of the rhexis, though the rhexis was secondarily enlarged to make the forces acting on the rhexis margin symmetric so that the late decentration of the intraocular lens can be avoided. Here, an apparently looking round rhexis became oval after the implantation of a 3-piece lens, and this is because of the weakness of zonules 90 degrees away from the area of the haptic. And this rhexis has to be secondary enlarged to prevent late decentration and dislocation. So because of the individual variability in corneal magnification and pupil size, manual rhexis may not be always well centered and of the reproducible size. So a femtolaser can be used to produce a well centered rhexis of a precise diameter. Now coming to special situation, this patient had a mature intumescent cataract. So capsulorhexis in mature cataract is challenging because of 2 reasons. Once there is no red reflex, and so the visibility of anterior capsule is poor. So here trypan blue was used to stain the capsule, and the air bubble ensures uniform staining of the capsule and prevention of staining prevents staining of the endothelium. In the second place, the capsular back pressure is very high and the anterior capsule is convex. In this case, there is a risk of extension of the rhexis to the periphery. So you should inflate the anterior chamber nicely with OVD to keep the anterior capsule flap. And a primary small rhexis was done, and then the cortex was aspirated to reduce the back pressure. Once the cortex is aspirated, the back pressure comes down, and you can again refill the anterior chamber with OVD, and a tangential nick was made on the rhexis margin, and now you can safely extend the rhexis to the desired size because the back pressure is not there. Now in this patient, the lens intumescent flucky cortex, we could not aspirate it. So as you can see, there was still intumescence in the periphery and the rhexis went out to the periphery and I could not retrieve it. So again, after injecting OVD, the nick was made on the opposite end of the rhexis and the rhexis was completed. Since there was compromise in the rhexis, violent hydrodissection was not done and the cortex at the area of the rhexis extension was removed last. Now, in this patient with intermittent cataract, in this area, the rhexis was trying to go to the periphery. So OVD was injected to make the flap flat, and then using a microrhexis forceps for better control, this was pulled centripetally for a better control, and the rhexis was completed. This is the Brian Little rescue maneuver. And in this patient with mature cataract, when both the instruments were taken out, there was a sudden shallowing of anterior chamber, and the Argentine flag sign was produced. So the cortex in the center was aspirated, and then OVD was injected, and 2 nicks were made on the either side of the rhexis, and the rhexis was completed. And the phacoemulsification was done using low parameters. If you see here, the flap is motile, and then it is everted. So this means the rhexis extension has not gone onto the posterior capsule, and so you can safely place an intraocular lens inside the bag. Now coming to incisions, the phacoincision should be secure, self-sealing, astigmatically neutral, and of appropriate size. So there is increased risk of iris prolapse and wound leak with short tunnel, and in long tunnel there is difficulty in manipulating the instruments, and the visibility will be poor, and there is increased risk of Descemet's membrane detachment. So in this patient, while introducing the phaco probe, more force was used, and then there was a small Descemet's detachment at the wound area, which was there was a small Descemet's membrane detachment in the wound area that was overlooked because the pupil was coming down. And then this phaco was completed by, if there is a Descemet's detachment which is large, then you should take a new site for creating a clear cornea incision, and phaco can be completed safely through that. Stuck full slide. Next slide. Sorry for that. So here there was a large Descemet's membrane detachment was there. Oh, it's again getting stuck. So I'll go to the next video. So in this patient, when the irrigation was started, there was accumulation of fluid under the conjunctiva, and then there was 360-degree perilimbal chemosis with pooling of fluid on top of cornea, which was impairing visualization. So here, because of the excessive phaco energy and inadequate irrigation aspiration, there was wound burn. This is evidenced by the whitening of the wound margins. So in these conditions, you can place a suture. And to summarize, a perfect capsulorhexis and incision are extremely important for safe phacoemulsification. Thank you.
Thank you.
Sorry for the delay.
Thank you, Dr. Sandhya. With those videos were great, and you have touched upon the nuances of incisions and importance of a good capsulorhexis.